I made the same remark the last time the conference was here in Rome, and then it was a little bit laughed about. But I'm more and more thinking about HTLV when I hear all these talks. So clonal expansion, and also a remark that a question that was asked, even if the virus is defective, you're not sure that it's not immunogenic anymore, because some proteins can be still expressed, and in HTLV at least that's the case, that these even defective virus cells can be attacked by the immune system. And so maybe there's a lot of these assays that have been done in HTLV research already, but of course HIV gets a lot more money than HTLV research, so there's a lot of things that I see you guys doing that we might actually benefit from now in HTLV research. And just as a remark that maybe HIV-2 is in the middle of the two, like what does this all mean for HIV-2? HIV-2 has a almost undetectable viral load. It's maybe, we don't know because nobody is doing it, maybe there's even more clonal expansion in HIV-2 compared to HIV-1, I don't know. Just what are the thoughts of the panel?
Okay, Timothy, you want to answer that?
Yeah, I mean, I think that's actually a really interesting comparison. Looking at HTLV as another retrovirus, obviously, that is immunogenic. You know, what's interesting is that there's a strong correlation between HTLV and cancer. And that probably has to do with the fact that there's proliferation and what you're saying. What I find striking is that with HIV, despite a huge burden of HIV, active replication, we see almost no T-cell lymphomas of CD4 T cells in HIV, where we would with HTLV. You see a lot of HTLV-related tumors, especially in Asia, where it's highly competent. So that's interesting to me that all the lymphomas that we are seeing are probably due to immune recognizance issues and things like that. But I think it is definitely, I think you're completely right, though, to be looking at these other related lentiviruses or other things that are going on, because I think there really is something that we could learn too. And HIV-2, I think is being mostly like SIV, in that it's probably less replicative. Probably it's just not adapted for human. It's meant to be in a monkey, not in a person. So it's more than just, I think, integration site, but it has to do with the host immune responses, intrinsic immunity, everything from ApoBec to TRIM to TIM to basically your innate intrinsic immunity as well. So it's fairly complicated, but I think it's actually, looking outside HIV is definitely a wise thing to do. But that was just an interesting observation.
Just one remark about ATL, adult T-cell lymphoma in HTLV. It's very rare also in HTLV because most patients are just asymptomatic. So it's not.
Yeah, that's a really good point. So maybe it's just a smaller number. I mean, we are collecting T-cell lymphoma patients in our cohort, and we'll be hopefully looking at this question whether there is, if it was the HIV that was directly related. But there's not many. I think we only have 3 or 4 right now at several sites in the U.S. But.
Okay, thank you. I have a question for Monique, actually. So in the presentation for Rolf that Elena gave about her case where she really tries to tease out if the patient is now cured or not, I mean, I have the impression that you try to increase the number of PCRs on different tissues. And if we go back to the Timothy Brown patient and the work that Jukul has done, I mean, he also had positive signals in some of his PCRs at a certain time point. So I'm not convinced that increasing the number of PCRs, I mean, even with digital droplet PCR, where you have the issue with the false positives, will give you the answer. Or what do you think about that?
I think that's a very good question. That's one of the questions I wrote down, but then for Timothy. My question would be, what would we find in Timothy Brown now if we would do the same kind of analysis? And that's a little bit analogy of what you are asking. To come back to the false positives, I'm not sure if it's false positive, like technically false positive, because we really control for that in a very specialized setting. So I don't think it's like a false positive signal that we detect because of a contamination or something. I really genuinely believe that we do detect in this particular patient still HIV DNA, but it could as well be like a tiny fragment. I mean, that's something that we do not know. And also, as you already alluded on, I mean, in the Berlin patient, there was HIV DNA there. There was HIV RNA there. Some of it was like a contamination, as appeared later on, but it was there. But they never looked in T-cell subsets. So I would really wonder, what we would still find now in the Berlin patient if we would check.
So actually, it's interesting. We actually did go back. I forgot to put the slide in. I feel after it was perfectly set up, but I forgot to put the slide in. We actually, for the Boston patients A and B during the leukapheresis, we actually did go back and isolate subsets. Effector memory, central memory, transitional memory, stem cell memory. And we did find a very low signal in one of our patients from the terminally differentiated effector memory, these TEMRA cells, which is weird because those are short, they should be short-lived, and why are they there, and why are they? So maybe that was, it wasn't high enough to do any sequencing, and we tried really hard, but we weren't able to do it. And that's the problem with all of these, is that there's such low levels that to get quality sequences, especially if you're trying to get full-length sequencing to see about integrity of the virus, it's very difficult to do. So yeah, I think, the question is it true signal? And it probably is it, remember, most of the DNA is junk, right? It just doesn't do anything. So you just hope that you're stochastically below the threshold of that 4 log reduction, and then what you're finding is just fossilized DNA. So that's your hope. Unfortunately, I think that even if you competitively resample, obviously if you grew something in outgrowth, that would be an indication that you might not want to do a treatment interruption, right? So when we designed our treatment interruption protocol for the Boston patients, our threshold was the outgrowth assay. It was not the DNA. We didn't actually know about the subsets yet. It was negative as well, but it was the outgrowth assay that we were going to do, because if you don't have outgrowth, how do you know? How do you know this is not just fossilized or junk DNA? So that's just how we did. And I think unfortunately, unless you're able to get this to grow in a mouse model or in a traditional QVOA, you just won't know. Even if you try to get sequences, you still may not know. What if it's an intact sequence, but it's not on a site that's going to be integrated, in integration sites that's not active, for example, or just not going to be. So I think the only way to do it, unfortunately, is still a treatment interruption. It makes us all nervous, obviously, but.
So, Linus, to answer your question. Just to be honest, I mean, we are just among us, so this was purely technically driven in the beginning. When you don't see anything, you always ask yourself the question, am I right? So doing anything wrong in the lab, how certain can I be about my result that I see now? So you repeat the experiment, you increase the input, and just to verify what you see. And what we believe is that we might see at least traces of the virus in the body somewhere. So we expect to see a positive signal somewhere. We are not sure if that is really a replicative virus, and definitely this is something different than the answer, because coming back to the original observations, when you see freshly infected patients or newly infected patients, even mother-to-child transmission, where you observed, where there's a nice and good work from Gabriella Scarlatti from Milan on a big group of mother-to-child transmissions in the 90s, and she could observe no X4, what we call now X4 variant, in this newly infected babies from the X4 mothers. So there must be something different in the immune system, that it is most likely to control the X4 virus in the beginning. This definitely did not happen in the SN patient, so that was a different thing. So there's a lot of things we have to learn. And one very important remark is about the Düsseldorf patient. Deciding to stop therapy or not was also a question from the ethical committee, saying what harm do you do to the patient if you stop or carry on the treatment? So what side effects are on the medication? So is it really worth taking the drugs off? And we had to answer these questions. Is it worth taking the drugs off now? Are we sure or not sure? What will happen when we take the drugs off? So we will observe such a rapid rebound as in the Boston patients. Is the immune system able to control the X4 viruses if they are there? Open questions.
So this question is for both Javier and Tim. One of the problems that I understood is that this incoming immune system from the donor has never seen HIV, so it's not. So Delta 32 protects it from becoming infected, but then other than unspecific effects from the transplantation, these cells are still, they are not trained to fight HIV. So what can be done? Are you exploring anything? Is there like some gene therapy? What can be done?
There are different possibilities and strategies that could be used in there, like, training the incoming cells to fight HIV. The problem is that this is at the end a kind of a prophylactic vaccination. So you have to really deal with what you want to control, and you have to expose the real virus of that patient to the new cell system. And one thing that I've learned in this project is that any immune intervention that you may want to do in these patients, that makes hematologists very nervous. So one of the possibilities, it's been described very recently that the PD-1 system is strongly acting in lymph nodes. So in people who are under transplantation systems, the PD-1 is strongly inhibiting CD8 T cell responses against lymphoma in lymph node, but not in other tissues. So there is kind of compartmentalization in the body. So if you ask the hematologist as well, in patients like our patient one, or maybe the Dusseldorf patient, would you use checkpoint inhibitors to, try to release this signal and fight against still any residual cell? The hematologist will say, don't touch it. We have in the perfect equilibrium. He's doing well with his hematological disease. Don't touch it. We don't want to do any immunological intervention. So, we're thinking about that, but we don't find the agreement with the hematologist to really come with an immune stimulation of the immune system. This is tricky because anything you do ex vivo to learn things is only in peripheral blood. And we start realizing that lymphoid tissue is going to be the clue in all this topic. If there is anything left, it's going to be in the lymphoid tissue areas.
Microphone one, Thomas.
On the basis of Annemie's suggestion and the observation of a clonal expansion in some patients, I'm just not knowledgeable about that. Does any one of you know what the situation is in SIV and African green monkeys that don't get sick but have a proliferative, if you wish, replication? Is the situation any different there? Do we know anything about DNA over time in the monkey model?
So, in order to generate a data bank of the clones, this has been done in SIV also. So the situation there is quite similar, because that has been done by Steve Hughes to generate his data bank. Yeah.
So as far as I know, just to complete your answer, is that the DNA in the African green monkey and the sooty monkey models is still there. We've been putting together a cohort, what we call viremic non-progressors individuals, so people with high levels of viremia, non-treatment, and still don't get sick and don't lose CD4 T cells. And if you look for proviral DNA, it's there, and it's probably mainly related to the immune system that they don't get activated. But the virus is still there very clearly.
The clonal expansion also?
Oh, no, the clonal, we haven't looked at that.
Yeah, just following up on the previous provocation, is there something that can be done on the donors? You identified donors which should be dedicated to donation to HIV patients. Maybe some of them would volunteer for being, immune stimulated against HIV antigens. So it's just an hypothesis, obviously. And the other, how much do you think that the repeated stem cell transplantation, the repeated cycles may play a role? In the Berlin patient, maybe they played a role because after the first he had a relapse and also for HIV, if I remember well.
Actually, I want to follow up on that question too, is that what's also interesting about the Berlin patient is that he had relapse of disease, which means that he still had recipient hematopoietic cells in his system. Maybe not capable of harboring HIV, but they were there. Yet there still was no HIV that was detected. So that may have been just because there was so much for that initial non-CCR5 response. But there certainly could be, the fact that he underwent 2 certainly could have played a role. It's really hard to know, but I think it certainly could have. I mean, you're giving them another cytotoxic shock followed by another fresh infusion of these donor cells that can then basically have these graft versus leukemic, graft versus hematopoietic effects that eventually over time will clear out infected cells. So it's possible that it gave it a boost, yeah. We actually, in patient B, in our cohort, we only lost DNA detection after he had a donor lymphocyte infusion for poor engraftment. So had an initial transplant, didn't engraft very well, so sometimes they'll give a little extra, they'll give some white cells back in, some stem cells, I'm sorry, just to try to boost or a combination thereof. He had a donor lymphocyte infusion, and actually after that developed full donor chimerism and then lost DNA detection. So certainly, these repeated events may have actually made us, and he also went longer without after treatment interruption. So that could have played a role. Yeah.
And with
Düsseldorf patient also received 2 times transplantation.
And with regards to the first question, can we educate the donor cells for doing that? This is a practical issue actually, because 2 things. First is that most of the times we deal with anonymous donors. If it's cord blood, there's nothing we can do with that. If it's bone marrow donors, most of the time they're anonymous as well. We could only deal with transplantations with siblings. And the problem there is that we always run out of time in these situations. I mean, we don't have time to start vaccinating the donor with HIV vaccines and wait to develop immunity and then transplant the cells. I mean, it's not practical.
I think it should be explored. I know it's difficult, but you can overcome practical problems in some way. Yeah.
Even donors who are exposed and negative.
Yeah, indeed. In fact, they are not receptive to HIV, so some of them may be exposed and infected.
Yeah. So, Monique?
Yeah, I have actually a question for Tim. And my question is really regarding the NK response that you do see initially. Do you have any clue whether the response that you do see by sequencing CUR or whatever, if it's like a clonal response that you see, or if it's a target against different antigens? Because that could also give us an idea of, what kind of virus is still lingering around, or whether it's like producing still different proteins, yes or no?
Yeah, so we haven't looked at activation to response to specific peptides, for example. What we do know is that there is more activation of these NK cells and even NKT cells in the presence of clonal HIV. So in our ex vivo modeling that Louise is doing, we use just a single clone, just a lab-derived strain, so that we infect. By the way, we're taking uninfected patients that have undergone transplant because we can match HLA KIR types. We can control for a lot of afters. We actually have about 950 transplant patient samples that we have stored that we can choose from, and we can match HLA type and KIR type. So we're exploring that now. The question is whether it's going to be a general response or if it's going to be specific to various region, to various. We're not sure. Usually with NK cell responses, it's not a viral specific response other than the virus is changing the self-recognition of the cell. So for example, that when a cell reactivates, it's going to produce an F protein which may downregulate HLA-B. HLA-B can interact if you're a BW4 HLA motif with KIR, the KIR3, the KIR 2DLs, the 2DSs. So if you have the right KIR type, then if you downregulate HLA-B, you may actually disinhibit your NK cell. So you're actually allowing them to kill the cells, not necessarily through the specifics of HIV, but the general proteins that they're downregulated. For example, like CD4 is downregulated during replication, so is HLA. So it's that loss of what we would expect on the receptor that the NK cell recognizes. So it's specific, but it's a general specific response, if that makes sense. So it's the fact that it's reactivating virus that it's targeting, not the specifics of the virus itself. So it's really complicated, actually. And it may actually, the fact that Louise is seeing it in in a subset of patients and not the whole cohort in the ex vivo modeling suggests there really is genetic kind of matching that's in play, and that would suggest that it is really the specific, more non-specific, but HIV-related phenomenon that we're seeing. That may not make any sense whatsoever, but...
One thing you didn't talk about, but which was a bit worrying to me, was, Tim, maybe you want to comment on it a bit further, was your speculation that perhaps Delta CCR5 is dangerous to be transplanted with.
Yeah, and I was trying to be careful at the end of the talk because we don't really understand what's going on yet with Delta 32. I think we need to learn more. It is surprising that we're seeing high mortality in the CCR5 transplanted patients, the Delta 32 patients. Again, it's a small sample size. It's just a sampling error. We don't know. We're also seeing a higher mortality in our own wild-type donor population as well with HIV locally. So it may be, whether it's an HIV effect or CCR5, we just don't know. But I think it definitely deserves more attention to know, as we're thinking about doing this, are we actually putting or potentially putting an individual at risk? And it's a possibility, and I think that it certainly needs to be explored. We're going to be looking at that ex vivo first because it's easier to do. It's low-hanging fruit. We don't have to worry about trying to find this. But for example, one of the thoughts is if we look at a lot of the patients that have died with Delta 32 stem, and again, this is all anecdotal, right? I mean, this is not just kind of looking through case reports. People are having either recurrent tumors. So that's one big one. Or there may be some, I think the Santiago patient had acute lung infection or acute lung injury. Whether it was infectious or not was never determined. But if you have recurrence of a tumor, it suggests that you may not have a strong enough beneficial graft versus host or graft versus leukemic effect, which you do want. So it's this balance between you want enough graft versus host effects to keep the tumor at bay, to keep the hematopoietic compartment all donor and 100% donor, even in tissue, which is another question, is what's the donor chimerism in these tissues. But you don't want too much graft versus host disease because that's obviously increased mortality for transplant. So I think there's this fine balance that we have to target. And the question is, what does Delta 32 do to that balance? Does it throw it off? For example, does it allow more tumor relapse because maybe we know that CCR5 may be related to chemo attraction of lymphocytes, for example. So if you're not trafficking those to the right tissues or to the right sources, because you have a Delta 32 transplant, then that is potential. We were talking last night, actually, just informally, that people that are Delta 32 homozygous normally live perfectly happy, normal, healthy lives. But they've also adapted to, they probably also have adapted to use or other co-receptors and things like that to fight viral infections. I know in mice, West Nile's can be more neurotropic and more dangerous, but in people don't seem to have an increased risk. So in general, so the thought is you're taking a patient that was not Delta 32 homozygous, did not have that compensatory basically evolution of their immune system as they developed and they grew since childhood, and all of a sudden you put a Delta 32 immune system in. What does that do to the recipient? I don't think we know. But it brings up, I do agree that it brings up some serious questions about is there an increased risk of morbidity or mortality if you use Delta, just simply because of the Delta 32. Now, there is evidence in non-HIV infected patients that I showed a little bit of, and there was also a GWAS study at the Fred Hutchinson a couple years ago as well, where they were looking at genes that associated with GVHD and outcome. And in that one, CCR5 did not come through as a strong predictor. But again, that's HIV uninfected individuals, so maybe that's different. But yeah, definitely warrants further study.
There are data there from the European bone marrow transplantation group where they compare people who were HIV positive and non-HIV positive and allogeneic stem cell transplantation. And what is clear that the mortality ratio is greater in HIV positive individual. The numbers cannot be split out by Delta 32, non-Delta 32, but it's very clear that the likelihood of reconstitution is lower in HIV-infected individuals.
Okay, there is maybe time for a last question, Javier, Roger.
Yeah. So it's just, I'm sure it's a speculation, but essentially the Delta 32 is to protect the new immune system. So you can also do that with drugs, with antiviral treatment or fancy antibodies or whatever. So could you speculate, would have, in the case of the Boston patients, if you would have kept patients for a longer time on therapy, do you think that the chances, would that have delayed or no?
Yeah, so I think that, so thinking about the graft versus host effects, the beneficial ones, it takes a while. So after your transplant, you have this massive reduction, but it's this microchimerism. So you can reach 100% blood chimerism by your clinical assays, but still have donor recipient cells and tissue. So it would take, so our hypothesis is that it would take several years, on the order of years, in order to really clear out, or for those beneficial donor versus host responses to clear out residual infected cells, either by specific or non-specific means, so either way. So our original thought was that patient A would take longer to rebound because it was 4 years after, whereas patient B, who actually went the longest, was only 2 years out, or 2.5 years out. But again, 2 patients, what can we make of that? But I think that the longer you go, so there's a French case from 2007 where they went for, I think there was after their transplant, fully myoablative. Oh no, it was reduced intense. Maybe someone here that knows this. Anyway, I can't remember. They had a transplant. It was full, right? Oh, because there's no French. Okay. Anyways, no French. The patients stopped ART because they thought they were having graft versus. They thought they had a medication effect. Turned out to be graft versus host disease. But they stopped ART, and it was only about 8 months after their transplant, and HIV rebounded within like a week. It was like we would see normally with any of the treatment interruption trials. Within a few weeks, vast majority of people rebound. They had the same thing. They rebounded. Wasn't as high as our patients, but they did rebound very rapidly. But they were only, again, they looked at their peripheral chimerism by clinical testing, which can have a couple % error, and there probably was active tissue, or there could have been active RNA production in tissues as well. So I think the longer you go, the better you are, and the more of a chance that you are to do that. When we looked at our modeling in our recent paper as well, if you allow more time for those residual cells to go down, you essentially you increase that log reduction in your latent reservoir, and you should actually expect to have longer rebound time, longer times before rebound if you're longer after transplant before you stop.
The marker, imagine that you reach a point, the marker would be the level of DNA.
Yeah. The problem is that level is below what we can currently detect, at least for what we've seen. That it has to be below, at least in peripheral blood. I think in tissue, again, and Javier mentioned that tissue is key, it's going to be absolutely key, and this is why I thought the epistem cohort is fantastic, because you're now finding that, not in gut, but in lymphoid tissue, there is at least LTR evidence of some type of HIV. So it's certainly possible that you're going to have to wait for these tissues to essentially equilibrate for that the donor cells to really clear them out. But again, you'd have to do a lot of tissue biopsy, I think, and you're going to have to, remember, if you do one tissue biopsy of one lymph node and you've had a 4 log reduction in your reservoir, you're not going to find it, because it's spread throughout the entire body. So we calculate that patient B, Gary, only had about 50 to 100 cells that were harbored replication competent HIV left after stem cell transplantation. So to try to find that, it's going to be really tricky. So it's below that threshold that would determine the length. So
actually I have a final question for you, Tim, as well, and taking advantage of the audience and your experience as well. So if you had to repeat the treatment interruption in a new patient, what would you do differently in terms of testing, and especially in order to avoid any acute retroviral syndrome?
Yeah, so we've thought about this a lot. I'm sure you guys have thought about this too. It's tough. We're finding that virus rebounds within days. That one of our patients, it was literally, I think, 4.5 days after their last clinical viral load was negative, that they had, 600, and then 3 days later, 1 million or something. So I mean, it just goes right up, and it's what we'd expect with acute infection as well. So it's fast. So we actually looked mathematically to see how many times you'd have to sample them to catch rebound within a certain time frame, and you have to do it very often if you really want to catch it. Now we initially spaced ours out. We said, if we make it to 3 months, we're going to space out to once a week instead of twice a week. And then we're going to do it every other week. And then we're going to do it every 3rd week, because we didn't know what we were doing. And we thought, okay, if they're going that long, the chances of them are rebounding. And it's true. The longer you go, the more of a chance you are to stay and not rebound, right? So the longer you go, the longer you're going to go. The problem with that, though, is that you can't, when you do come back, you're going to come back like this. So unless you're doing rapid, frequent testing, you're going to miss it. So I would suggest very often, and I know it's expensive and it's hard to do, but if you really want to keep people from having acute retroviral syndrome, it may not be possible, and you may have to do it, on the order of every few days.
Well, thank you all for staying here. Very exciting session. Thank you to the panel.